Please do send them forward. I just want to make one quick announcement. There was someone who submitted a question about a Tarlov cyst. You don't have to raise your hand, but there's Lisa over here with her hand up is very interested to meet you. If you're interested, please do connect. Questions about Tarlov cysts, something in common. Okay. All right, we just have a, yeah. Over there. Okay, so just a few more questions. This one for Dr. Schievink.
Thank you.
This is a patient whose leak has not been found, but symptoms are worsening. So what's going on? What is this person supposed to do?
Well, if you have superficial siderosis and you know, I guess by MRI, that you also have a leak, then you just need to keep looking until you find it.
So how often would you recommend getting tested? Is there a specific time, like when they get a headache, maybe from a bleed or something?
Yeah, that's a really good question. We don't think that makes much of a difference. Patients sometimes, they do jumping jacks before we do their myelogram, you know, thinking that that might affect the likelihood of finding a leak. I don't think it does, but makes the person feel better. So, you know, in order to identify a leak that you don't see on an MRI, you need to do these invasive tests. So they always involve a spinal tap. We do them under general anesthesia, so we don't do it like, you know, every day for 30 days in a row. There's some time in between.
Okay, there's a question from online. They noted that I've said it takes a long time for FARAPROX to work, that it takes years and years, and that it would be great if we had an expedited way to do this. And I don't have one, but tomorrow we're going to be talking about different research ideas. The panel will be up here. We'll be brainstorming different ideas, so stay tuned for that. Dr. Haddad, can a patient with superficial siderosis still donate blood or platelets? And can they still do it if they're using deferoprone?
Technically, yes, they can. Unless you're anemic, then the blood bank will stop you when they check you. And remember, they have to run some tests on you before they allow you to do that. If you're significantly anemic, the answer is no. If you're anemic, the answer is no. If you are normal, if you have normal hemoglobin, you'll pass the test. Superficial siderosis is not one of the diseases that negate the candidacy of any donor. Or
Natallia, question for you. Once you've developed deafness or hearing loss on one side, is it inevitable that hearing loss will spread to the other side?
And thank you, very good question. From experience, when there is asymmetry, most of the times there is another risk factor for the hearing loss in that particular ear. And to answer, in all honesty, I don't know. Like we wouldn't know for answers for many other things. The best thing and the most important thing would probably be to observe. So have regular checks, and again and again come back to, can we find the leak? Can we fix it? Can we offer a treatment, or can we get a treatment to prevent any possible deterioration, at least in theory, of symptoms?
Okay. Rhys, any tips on managing the number of appointments with various specialists?
Sorry, can you repeat that, please?
Yeah, tips. We want tips from you about how to manage the number of appointments with various specialists.
Yeah, so I kind of got into the niche of this, I guess, now. It's just keep a record and write down all your symptoms, and I've made my own chronology of all my surgical procedures and everything I've had done. I keep logs of my results and map them in chronological order. and take this and update it every time I have a test and take it to my next appointment, because otherwise you spend a lot of time explaining to a new doctor or a doctor in a different capacity about what's going on. So it's a lot of record keeping, and I use my computer a lot to log all my results and everything as well, and just so I have an understanding of what my condition as well. And I do feel it's helped me to learn about my own condition, and in respect to superficial siderosis in general, to have an idea of what's going on. And I would encourage people to have some sort of understanding of what's going on in their own health. Not because you're the one dealing with it, and the doctors, they can see what you've got, but they can't feel it. You live with it on a day-to-day basis, and I think in hindsight that's quite an advantage to know what's going on and to be dealing with it, and you can get a bit of an understanding of it yourself. But yeah, it's difficult managing the different appointments, going back and forth. We've got London, Cardiff, Newport. I've travelled all over the UK for different appointments. It's very time consuming, and I couldn't have done it without my mum and dad, particularly my mum. She's been my rock.
I was wondering, Professor Werring, because of the multidisciplinary clinic you have, when you see a patient, do they have an appointment with you and an appointment with, let's say, a neurosurgeon and the occupational therapist and the physical therapist and the audiologist, like all on one day? Or some headache centers in the US are like that.
Yeah, no, we don't do that. We have a virtual MDT, basically. So we get the neurosurgeon, the neurologist, neuroradiologist, and sometimes the hematologist, and they all dial in on Teams. We review the scans, we review the CSF results, we review the clinical histories, and then we come up with a management plan. And then it might be that they then have to go and see the surgeon to discuss the repair, or they may have to go and see the hematologist to discuss the monitoring, or we may say, well, this person needs to go and see the neuropsychologist because they've got a high burden of anxiety and depression. So we do a virtual one to get all the opinions, and then we signpost the relevant specialist from there.
Sorry, please.
Yeah, we also have a facility, at least I know when I've been arranging follow-ups or referring patients on to, say, neuropsychology or other appointments, I always try to request to see if the appointment can be facilitated to be given on the same day, particularly for patients who travel from outside of London. And our trust is very understanding because we do get a lot of patients who come from quite afar. So even the cost of travel alone is quite a lot. So we try to facilitate that within the trust as much as possible, yeah.
I might just add, if we had more resources, I would love to have all the doctors all together and all the specialists and see the patient all together. That would be my sort of dream clinic if we could do it like that. But just for logistical reasons, we do it virtually.
It's also difficult with that model when a patient cancels their appointment. You have like 6 specialists who have a break in their day.
Coffee break, I guess, right? Dr. Schievink, if you can hold on to that. Someone online heard us talking that one of the most common causes of superficial siderosis is from head and neck trauma. So why aren't surgeons, spine surgeons, educated on superficial siderosis at all? And what can be done to educate them?
Well, we have that same dilemma just for CSF leaks in general. So we're working on a medical school curriculum because that's where you reach the largest number of physicians. I think it's so common to have head and neck trauma. So I think it's difficult to say, when somebody has a head and neck trauma, you have to be careful that they might develop superficial siderosis just because it's so prevalent.
That's fair. Okay. Let's get a consensus on the panel. We kind of talked about cases like this with a medium amount of superficial siderosis on the MRI, but not a lot of symptoms yet. Maybe never, but minimal symptoms, heavy or moderate deposits on the MRI. who's treating with deferriprone? Maybe raise your hand. I think I probably would. Two out of 6?
If the CSF was active, yes.
If there was a bleed, yeah. If there's an active bleed, if CSF was active.
And this is where you do not know the cause of the superficial siderosis.
Not part of the question, but let's say the CSF leak has been repaired. Well, yeah. I guess there's 2 different situations. One is with an active leak, and one is without an active leak. But, okay. Dr. Schievink, since you have the mic, maybe you can answer this question. Should every person with superficial siderosis get a lumbar puncture to see if they have an active bleed at the onset of their diagnosis?
For me, that's a bit of an irrelevant question because everybody I see with superficial siderosis, unless there's prior surgery, but if we're looking for a CSF leak, we would do a lumbar puncture anyway in order to do the myelogram. And then we would examine the CSF.
Good. Anybody else want to add to that? Does anybody on the panel have a patient with superficial siderosis related to diabetes? There's a question. Anybody with diabetes? No? Okay. There's another question here about why this person is taking deferriprone and actually feels better while they're taking deferriprone. We're talking about stopping the degeneration, but not really making things better. Do you have a sense of maybe why someone would feel better while taking deferriprone? Is it that they're maybe psychological, they're empowering their own care? I mean, what's going on?
Most of the people don't feel better on deferriprone. So I would chalk it off as 15% placebo effect. But I cannot argue with the person that's feeling better. If I can't make you feel better and you feel better, go for it. God bless you.
Natallia, maybe. Nystagmus. Can you explain what nystagmus is and maybe explain why it happens with superficial siderosis? There's an online question about that.
So nystagmus is this pendulum-like movement of eyes that is involuntary, meaning we cannot control it. And this is tightly affected or generated, I should say, in accordance with this, as I referred to in my slide, by this multi-system vestibular network, including the oculomotor nuclei. So the reason for nystagmus can be several-fold, and nystagmus is actually one of the fantastic ways, or examining the eyes for nystagmus is one of the fantastic ways trying to figure out what's wrong and where the problem is. So there are different types of nystagmus coming from congenital, meaning that somebody's been born with it and there's nothing to worry about, or something that is associated with the inner ear problem, so the problem lying with the end organ of the vestibular system, or more central, meaning that there is central vestibular involvement. So nystagmus per se, that it's an abnormal finding. So in normal populations, nystagmus is not observed. But the next question then to ask your doctor is what type of nystagmus it is and what does that indicate. So I wouldn't venture to explain it in more detail. I think we will be here for many hours. But have a chat with your physician who identified the nystagmus to identify whether, or to clarify whether it is related to the inner ear or something to do with the brain.
Thank you. And this is our last question. I saved it to the end. The question deals with hope. This is a person online who asked whether you would prescribe deferriprone even just to empower a patient and give them hope. And if not that, what other strategies are there that you use to empower patients? Maybe Rhys can also comment. What kind of strategies could improve their resilience and give a patient hope?
So I'll mention that one about empowerment. I do think being on deferriprone is empowering in itself, but I do think it's about understanding the condition as well. I think when I found out I had superficial siderosis at first, I didn't know what it was. My neurologist, Tom, was uncertain. He contacted David, I can remember it, and so we were sort of on a learning curve together. And I think learning about it and learning ways to manage it along with my neurologist was a big benefactor for me, wanting to push myself to get the best and to stabilize my condition. Because when I first started losing my hearing, I was petrified. I can remember I couldn't play music anymore in the band, so I went on stage, and just because my one ear had already gone, and I still had the minor hearing loss in the other ear, and I just had this feeling that my other ear was going to go as well. So I started playing open mics in the local pubs, sort of riding my hearing out whilst it was lasting, and I had the clonus in my legs on the stage. I can remember someone shoving a chair underneath me as well at one of the open mic nights. But once I went through all the surgeries, I was keeping all the records and notes and trying to learn as I was going through it as well. And I think it was a case of I almost fighting for my life, almost like that's how I would put it. I felt like I had to do it to learn to manage it and to move on and get out of the predicament I was in. And I can empathize with everyone going through it. I know how hard it is. I went to surgeries, rock bottom, really depressed, wishing I didn't come out of the surgery. I was that bad at the time because I had to finish work. I've had to lost music. It's a really depressing condition. It's taken so much from me, and I just want to give back, and I hope I can empower and help everyone else who's going through this to push themselves and to get in the best possible position that they can to move their health forward and have the best life that they can.
That is a perfect closing message, Rhys and Natallia.
Yeah.
Yeah. Do you have anything to add, Natallia?
I just want to add that when I talk to patients, when I encounter patients in the clinic with superficial siderosis or even other complex neurological conditions, I always say, I have this patient who endured so much and they've been so positive and perseverant that you really have to be your own driving force for this and keep pushing, because there are people out there who are experiencing what you are experiencing, and there are also people out there who are willing to do the best they can to help you. So whenever, if you feel stuck, if you feel low, reach out.
Wow, that concludes Patient Day, but thank you so much to our panel for, I think they would have sat here another 10 hours and answered questions. Thank you so much. Just a heads up on tomorrow. So we have a good presentation at 9 o'clock tomorrow. So we're going to be back here, and everybody is welcome, even though it is Research Day. If you're in town still, come back. Coffee at 8:30, but the presentation doesn't start till 9. We have Susie at 9 o'clock. And then Dr. Levy will be leading the round table at 10 until they conclude. But the same group, we could watch them, and they're going to discuss amongst themselves and hopefully come up with some ideas that they can share with us and themselves that they're going to work on going forward. So thanks again for attending Patient Day. Just a couple quick announcements. I was asked if anybody wants to get contact information and share that with anybody. We have the room till 3. They won't really get too concerned, I bet, till 3:15. So do that right outside, where our sign-up table is. Just kind of mingle around there if you want to share your information with somebody and stay in touch. As I mentioned, Rhys is going to try to lead a monthly patient meeting on Teams. Also, our website, I mean, really, our website has a physician directory. We have a patient registry. If you haven't done that, you know, that's how, if we do find things out, that's how we're going to notify you. And then, like I say, we start tomorrow at 9 a.m. So I guess, am I missing anything, Rory? Thank you so much for attending. Thank you so much for our distinguished panel. We'll see you tomorrow.